Over to you, sir. Amit, sir, please share your presentation. Sir,
Right, sir.
speaking on tips and tricks, fracture reduction in IT fractures.
Okay. Right. Is my screen visible?
Yes, sir. No, no, no. Now it's gone.
No, it's gone.
Before it was visible.
Oh,
Yes, and now it is visible, sir.
all right, sir. Okay. So I think my work has been made very simple by Samarth and some speakers before me. What is important is that there are two or three things which is important. So if you get a difficult reduction, then you have got a difficult fracture. And if you got a difficult fracture, then the question of doing
Hello, sir. You are not audible, sir. Sir, you are not audible. Dr. Gunjar, can you hear Dr. Rastogi's voice?
No, sir.
No, sir. No, sir. None of us.
I thought it may be a problem with me or any others. Rastogi, sir?
I think there is a network problem there.
Okay. So can you give a call to him directly?
Yes, sir.
So in meantime, we can go ahead with some further questions. Let me see the questions in the panel box. Any specific scenario where you do the surgery in lateral position? Okay, that is a old question. And whole weight bearing. Yes, there is a very important question. Can you allow full weight bearing in reverse oblique fractures? Dr. Sumani has asked. Kapil sir, you have said that yes, in young patient, but otherwise to delay. So delay means how much delay, sir?
3 weeks in generally osteoporotic and old patient. I prefer to keep them non-weight bearing for 3 weeks.
Just I like to say, just 3 weeks is enough, or your radiological parameters will be working on that.
I'm sorry?
Whether you look at the parameters radiological
After 3 weeks?
3 weeks, or just a time span of 3 weeks is enough for you, sir?
No, I will just go with the time span, because after that, if I don't mobilize them, then they have all other type of complications.
But many times, sir, what I find is there is the gap, there is a necrosis of the bone ends, and you find a more gap at the subtrocutting or the reverse oblique, whatever you call. So in that scenario, what should be the ideology in that? Samar sir, are you there? Will you give an insight into it, sir?
Gap at what, 3 weeks, sir?
Yes, sir. You will find some, there is, because you know the bone end necrosis occurs.
where?
Yes, sir. Sir is the best. Sir is back. Okay, sir.
Yeah. So,
Please share, sir. 1 second, please share your screen, sir.
yes, sir, I am.
Now
Is
you're,
it
yes, sir, visible, sir. Please go ahead, sir.
visible now? Okay. So if you've got a difficult reduction scenario, I think my job was made much easier by previous speakers. So what happens when you get a difficult reduction? You get a proximal fragment abducted and externally rotated. You have got overriding, soft tissue interposition, comminuted fractures or segmental fractures, and rotation of one of the fragments. So what is important? Now let us look at this thing about where how are you going to position your patient on the table. I think it's already been explained. I do all my patients in a supine position on a fracture table. But what is important is this position. That the important thing is that if you have your perineal post on exactly in the middle of the pelvis, then you're going to push this fragment down. You've got to push this fragment out. And so the best way to do it is to have it on the opposite ischial tuberosity. And that's the best. I don't do any of my work on a lateral fracture table, but there are surgeons who are very, very fond of this position. I have no experience with this. So the proximal fragment may be in external rotation with the posterior sag. Most of the times this is what happens. And you've got externally rotating the foot and you can do a lot of maneuvers. We will come to that in this thing. But what is important is here. So the amount of rotation which you expect. If you've got a subtrochanteric fracture, you will be able to reduce it in external rotation. In trochanteric fractures, you need to put some internal rotation, and in intracapsular fractures, you need to put it in far more internal rotation than you would otherwise achieve. And this is a basic guideline. But this is also subject to the anatomy of the fracture which you are actually dealing with. So let's look at the sag of distal fragment. I do not know if you have got this attachment on your fracture tables. It's a very, very useful attachment. And it actually elevates the distal fragment, this fragment, and gets a reduction. Important thing is whether the proximal fragment is flexed or the distal fragments is sagging because of gravity. If it's sagging because of gravity, this thing is going to work. If it's just flexed, you need to do something else. And if you do not have, you can use a crutch if you do not have this thing. But what is important? So if you've got if you see this picture, you already got a reasonable antiversion in this thing. It's sagging down. So this one is actually sagging down. This is not flexed up, but this one is sagging down. You need to have both the levers in place. You need to have a lever which actually does not allow the fragment to go up, and you need to have another lever which actually elevates this distal fragment. Then you can get a fairly good reduction and you can proceed with your nailing. So this is another thing. So you can see this very far up. This one is going down. We got one spatula here. We got one spatula down below. And you get a fairly good reduction. You can see that anterior cortical line, nicely smooth and simple. And to keep all that in position, you've got a wire which is actually going across the head into the acetabulum, which transfixes everything, and you can then proceed with your nailing. You can also use a bone hook. So that's another technique which you can use. Put a bone hook, pull this fragment down, get your anterior cortical line reduction properly in the lateral view, and that is the more important view rather than the AP view. The AP view can misguide you. So, and then once you've got your bone hook in place, then you can put your nail in and use this thing. Subtrochanteric fractures, I think this picture has already been shown. You do a mini open reduction and you can use a clamp and we'll come to this. So this was one of this. This only works best if you've got a fairly large amount of bone here, which you can actually grasp on with your clamps. So, or a reverse oblique fracture, where you can see you could put a clamp there and get a fairly good reduction, nicely this thing, and then you have got then you've got easy access to this thing. Also, the entry point is this thing, and we'll come to this in a minute. So you got a fracture which is like this, in which the lateral, the distal fragment is far lateral in the medial. So this way you can actually, there is no varus. It's the whole fragment is actually is gone medially. So what you can do is bring it closer with any kind of hook and or this thing, and you can use a clamp to hold this thing, and then you can use other methods to stabilize this. We'll come to that also in a minute. But the best implant or the best reduction device, which I find, is a Steinman pin, or actually 2 or 3 Steinman pins used to percutaneously go into the greater trochanter to act as a joystick. Now see this. This is a massively rotated and a displaced fracture. You put a Steinman pin in it. This is what it looked like. This is what, once you derotate it, this is what it looks like now. You've got a nice access and you can proceed with your nailing. So this was a fracture, fairly comminuted fracture, externally rotated. You can see that lesser trochanter. You put a Steinman pin inside, derotate this entire fracture, and you get this thing. And you can still see that there is a small amount of gap, a small amount of sag here in the distal fragment, which we can correct easily by putting in a nail, which is this thing. This is an older variety of nail, which is 25 centimeters in an old picture. And similarly here, you see a fracture which has got a coronal split right up to the piriformis fossa. You can push this down by using a Steinman pin or a ball spike. You can transfix this by putting in a Steinman pin. Don't use simple K wires. Use a Steinman pin. It's much more rigid. And then you can get a fairly good entry. See how medial that entry is. Do not put it where the fracture is. So put it in the medial. If you go right down, actually this is the medial cortex. So you still got some amount of varus. And that nail is coming. Once you put the nail in properly, you see that the varus reduces. And once you've got the larger variety, you get a nice valgus fixation, and a nice anticord. This is a separate fragment which we didn't bother with much, but you still got, even after putting the nail in, you still have that spike there, which actually presses that fragment down till your fixation is complete. So you can transfix the fracture with the wire while in abduction. That way you will not have a residual varus, and then you can adduct. Used at least 2 wires. This is a technique popularized by Dr. Shiv Shankar and frequently used by me also. But instead of him using wires, I use Steinman pins, which are 3 millimeters. So these are intra-op pictures for the same this thing. You can put a wire. You've got a gap on the lateral aspect. You can push the fragment down a bit, and you can reduce this gap. So you've got a flex proximal fragment. You can also use a pressure from above by using a hammer or some metallic device which can push this fragment down. And this is how it looked like immediately on the fracture table. You can push this down. At the same time, you need to elevate your distal fragment a bit and transfix this by using pins. And then you can proceed with a fixation by using whichever nail you prefer, 2 screws or 1 screw, it depends upon you. So I think we've already seen this. A ball spike pusher is a useful device. What you need is actually a pointer reduction clamp, Steinman pins, a ball spike pusher, and a T-handle to manipulate that joystick. And of course, clamps. But recently, I've been starting using this as collinear clamps. And these are very, very useful if you've got a very large, especially in a reverse oblique scenario, where you can actually put this in, push the fragment down with, pull with one portion of the collinear clamp and push with the other portion to get a good reduction and avoid varus. And then you can use the same device to put in a cerclage wire for temporary stabilization. And then you can happily nail this fracture without any issues. Entry points, I don't use a tip of GT entry point anymore. What I actually use is something like a piriformis entry point for a fairly stable kind of fractures, and even more medial to the piriformis if you've got a fracture line which is going into the piriformis fossa. So lateral endpoints usually end up creating varus rather than actually, or fixing the fragment in varus without correcting the varus. So if your proximal fragment is internally rotated and adducted, before we take entry, guide wire must become parallel to lateral cortex in the AP view and the anterior cortex in the lateral view. So start only when the fracture is anatomically reduced. So if you got a reduction, then only start. Don't make an entry point and then expect the nail to reduce the fracture. So in general, that's the algorithm. Reduction in abduction, adduct the limb. If it's stable in adduction, proceed for PFN. If it displaces on adduction, transfix with K wires, adduct and proceed for PFN. If you got an irreducible reduction due to proximal fragment displacement, put in an anteroposterior Steinman pin for proximal fragment flexion and abduction, and a lateral medial pin in the posterior thirds of trochanter for adduction of proximal fragment. Reduce and transfix, adduct, and then proceed. If you've got a sag of the distal fragment, lift the distal fragment up with a unicortical shank screw and a T-handle, reduce, transfix, and proceed. Open reduction should be reserved for old fractures, for non-unions, and inability to obtain a complete reduction. But start fixation only after good reduction. Take care of sag, reduction in abduction and temporary fixation, and finally the entry point. Thank you.
Thank you very much, sir, for your inputs on this reduction of difficult fractures. And many times we really face difficulties, sir. And the keynote for this particular cases should be the surgeon should have all the armamentarium for reduction. That's
Absolutely.
much important. A thin spike, a hook,
Yeah.
a joystick, everything they should have on the table rather than just
Yeah.
pulling out with a odd instrument. They should have a right instrument for the reduction.
Yes, sir. What is interesting in the recent meetings, there's a lot of debate going on for the lateral wall.
Yes, sir.
So trochanter is broken, so what are you going to do and how you... What most people don't realize is that if you've got... There are 2 types of fracture trochanters. Trochanteric fractures and trochanteric fractures which actually fly off.
Okay.
So if you've got a fly-off trochanteric fracture, which means that the soft tissues around the trochanter, great trochanter, are completely torn, those are the only trochanters you actually need to fix. The rest of the trochanters already have a soft tissue covering all around them. And if you've got a good reduction, they will usually fall back into place. What you need to do is to make sure that your distal fragment doesn't medialize, one, and two, does not go into varus. So if it does not go into varus and does not medialize, then you will have ultimately a good result. But if you've got a trochanter which has flown off, then you need to bring that trochanter back, not because it is trochanter, but because it contains the attachment of the abductors.
Okay, sir.
So you need to bring it back and you fix it with something like a hook plate or something like that. That is the best implant actually to fix a trochanter, rather than putting a lot of steel wires and things like that, or sutures. So better to use a proper hook plate and stabilize everything.
Is there any other inputs from our panelist like to add on some inputs on this particular type of fractures or reduction techniques? So there is one question. What are the
Yes.
chances of femur neck fracture when you do more medial entry? And if there is neck fracture interrupt, how to deal with it?
Okay, so I have never had a neck fracture so far, ever. One, you do not do a medial entry to the point that you go into the neck. What you need to do is to go into the base of the neck if you've got a fracture. Also, remember that the proximal femoral nail has got a proximal diameter of somewhere around 12 millimeters. So you cannot go too far medial, otherwise actually you will break the neck. So what you need to do is go into the base of the neck. But important thing is get your fracture reduction right. What most of us go wrong is that the fracture line is extending into the piriformis fossa. We try and take an entry and inadvertently go into the fracture plane. That way, we do not ream anything, and when the big nail goes in, it tends to push the proximal fragment into varus. So important thing is get your reduction right, make sure you transfix your fracture, and then start reaming so that you ream both the sides equally and do not get a wedge effect.
Thank you, sir. So what I can really get out from this is there is very narrow space of error in this particular entry point. So the entry point has to be very perfect, because
Absolutely.
if you go medial, you can have AVN neck fracture. If you go lateral, then you have a trochanter fracture, blue water fracture. So everybody should be very particular while making the entry point. Thank you very much, sir, for your
Right.
inputs and your time on a very cool Sunday, sir. So thank you very much for your inputs, and I wish
Welcome.
you please can answer the questions for the delegate
Sure.
in the chat box, sir.
Yeah.
Next, I have our own faculty from Bhubaneswar, Dr. Sumanyu Tripathi, who